I often use this illusion that the CASCADE FH, which is the name of our registry, is the foundation of the foundation's work. We knew at the beginning that data drives policy changes, and you can't figure out where you want to go until you know where you are. And so we started this project not very long ago to ultimately improve the care for FH across the country and for all those individuals that are affected through examining the gaps in care and promoting the understanding. And I think we're starting to make some progress in that work. Just a few years ago, I think at our first summit, we started with 11 sites, and now we're up to 37 sites that are enrolling, and people are knocking on our door trying to get involved in this, and we'd love to continue to talk to you if you have FH patients that would like to participate. This is the progress. I love showing this slide because it continues to show steady enrollment. This is where we started back in the day. One of our patients at Stanford was the first to enroll, but then Sam Gidding got us started off, and then we had this huge uptick right before the first FH Summit. It always seems to go like that. There's always a bolus of patients, but now we've enrolled over 4,500 individuals with FH into this registry. These information is giving us an unprecedented insight into what's happening with patients, not only at a snapshot in time, but also longitudinally. We're following these patients over time to see how they're doing. Are we improving in their care? Are they getting better? Are they getting worse? What are the gaps in care, and how can we address them? One of the things I'll talk about at the end is our dreams of marrying these phenotypic data to genetic data, and as that becomes cheaper, we hope that that will become a reality. I'll just highlight a few of the demographic things. We've always been trying to build diversity into this registry, and we've made some headway in that regard. About 79% of the individuals are white, of which we have 6% of Hispanic ancestry, 8% African American ancestry. Particularly important to continue to enroll individuals with FH of non-white European ancestry. We have a good representation of both genders. We have a very large number of children, about 500 kids in the registry, one of the largest pediatric FH registries. We know that individuals with FH in general across the spectrum from heterozygous to homozygous FH have gaps in their care. We know that treated LDL remains suboptimal even at these great lipid clinics. So in adults, untreated LDL is 233, so these are highly affected individuals. Treated LDL is 140. In children, we have less options for medications. Treated LDL is 172. These are very poor numbers. Less than 10% of individuals achieve an LDL of less than 70. Only 17% of adults achieve an LDL below 100, which is something to really watch for. 47% of adults and 15% of pediatric heterozygous patients are on 2 or more lipid-lowering therapies. In homozygous FH, in adults, the treated LDL is 200. I mean, these patients have made great progress, but still have a long way to go. 31% of adult homozygous patients and 29% of kids are also on apheresis. These children with homozygous FH, starting with an LDL of 719, and through the great care of themselves, their parents, and their physicians, their LDLs get down to 223. But still, there's a huge way to go. I mean, almost nobody gets to an LDL that's sort of an optimal range. We know that ASCVD is very common both in male and female patients. It is more common in males. Coronary artery disease, 36% of males in our registry. Adult males have coronary artery disease, 25% of women. This is particularly true of things like myocardial infarction, stenting, et cetera. Homozygous FH, obviously the statistics are much worse. There doesn't seem to be as great a difference in gender here, but it's much smaller numbers, so we have to take that with the caveat there. So one of the things that we know from many studies is that women tend to get care that's less optimal than they should, and that also seems to be the case in FH. Women were getting statins less frequently, even when we adjusted for multiple risk factors. They had higher cholesterol levels, and that is something that really need to address moving forward. And I'm not just going to talk about race and ethnic gaps, but also gender gaps, and we're starting to see that treated LDL levels are higher in female patients. So in males, the treated LDLs are lower than in females, despite starting at the higher about the same levels. So, and this is a significant difference. Even after adjustment for risk factors, this difference remains. ASCVD at baseline differs significantly across race ethnic groups. And these are significant differences. I haven't highlighted all the significant differences, but in general, we do see that there are differences in ASCVD. In terms of gaps in care, there are gaps in care across race ethnic groups. Here we have the different race ethnic groups that are present in the registry. And you can see that although there are no significant differences in the baseline LDL levels, in terms of treated LDL levels, there are differences. And it turns out that even after adjusting for confounders, including coronary artery disease status, Asians and blacks are significantly less likely to achieve an LDL of less than 100. These data are going to be coming out soon in atherosclerosis, work led by Zahid Ahmad and Stephen Amrock. I think there's a few important directions the registry is going. One is the fact that we're following patients longitudinally. We collect data from patients every 6 months, so we can tell what's happening to their meds, what's happening to their cholesterol, what's happening to their heart attack risk, and actually whether they've actually had a heart attack or not. And that is giving us very important insights. We're finding that despite being cared for at some of the leading places around the country, FH patients are still at significantly elevated risk. And I think that's the crown jewel of CASCADE FH, is that we're following large numbers of these patients every 6 months with data entry. And so this is the type of data that we have. There's been 2,500 patients that have been prospectively enrolled so far. We have data on 1,766 that have had one follow-up visit at an average follow-up time of about a year. 778 have come for 2 follow-up visits, and 333 have come for 3 or more follow-up visits. As we continue to grow, obviously this will continue to improve, and we're looking forward to these data, but they're already showing some interesting findings. So with an average follow-up of 1.2 years, we have adult heterozygous patients and we have adult homozygous patients. 69 total events over the course of an average follow-up time of 1 year in heterozygous patients. Even though these patients are getting better care as they're enrolling in Cascade, their lipids are decreasing. These patients often come in undertreated. The lipid clinics are doing a good job in getting their LDLs down, but despite this, there are still a significant number of events that are happening. Homozygous patients, the statistics are even more alarming, because basically 69 events in 58 individuals, including 15 MIs, 9 bypass surgeries, 42 PCIs. Again, this is an average follow-up time of 1.2 years. So that's a roughly 4% event rate, hard event rate per year, which is pretty astonishing. 6 events in the homozygous patients in 30 individuals, about 17% event rate per year. Again, even at our lipid clinics, which we know are excellent. So this is alarming statistics and highlights the need to change. How are things changing over time? And one of the things obviously we've been tracking is the use of new lipid-lowering therapies, PCSK9 inhibitors, and more adoption of ezetimibe as it became generic. And so in adult heterozygous patients here, we have adult heterozygotes and pediatric heterozygous patients. We do see a significant uptick in PCSK9 inhibitor use and ezetimibe use over time. Statins are roughly the same. This is a shame that more than 75% of individuals are not on statins. I think that's a real important gap that needs to be changed. There needs to be much more education, much more campaigns against disinformation that prevents a lot of patients from being on statins. But we do see increased adoption of these novel lipid-lowering therapies. Heterozygous FH patients, obviously PCSK9 inhibitors are not approved for. There is an increase in statin use and ezetimibe use. Patients in the registry do have significantly lower LDL levels over time by 25 milligrams per deciliter in follow-up. And in kids, that is even more impressive, 90 milligram per deciliter. So we hope that actually participation in the registry by individuals will drive improved care. If you're having to enter data on patients every 6 months, we hope that causes site PIs and staff there to realize that what improvements need to be made. So I think that when we started the summit 5 years ago, we were in our infancy. And over the last 5 years, we've just seen a tremendous amount of growth, both in terms of clinical research and basic science research that's really giving us insights not only into new drugs, new therapies, new avenues for research, new ways to prevent heart disease, but also in delivery science. How do we improve that? How do we translate those discoveries? So what are the future goals and future directions? And I think these are always in alignment with our ultimate goals, to use these data to drive improved and more consistent care. We now have 37 sites that are enrolling. We want to be able to give sites specific dashboards. We want to allow sites in an anonymous way to compare themselves to their peers, see who has the best practices, who's doing the best job, how they can improve the care of their patients. We want to use data to drive policy and advocacy. We use these data all the time when we go to governmental organizations or payers, et cetera, to show how important distinguishing FH is from other conditions. We want to increase the utility of Cascade to give pathogenic insight. I think we've talked a lot about the marrying of genotypic data to phenotypic data, and ultimately it's going to be very important to try to do that as much as we can with Cascade. And finally, there's lots of new therapies that are on the horizon. How can we use Cascade FH to facilitate trial recruitment? How can we help sites? How can we facilitate that for individuals that are interested in participating? Everything that we do is patient-centric, and it relies on individuals with FH to help us help them. One of the best ways to do that is for individuals to contribute their data on themselves, so we learn who's doing well, who's doing poorly, what can we do to change things in the future, what can one patient do to benefit the rest of the community. So we urge you to sign up, go online for the CASCADE FH Registry. It takes a few minutes, but it's well worth it, not only for yourself, but also for your friends, family, and community.